Very good afternoon, everyone, and thank you so much for being here to listen even to the last talk of the day, I think. All of you I know have been present here since morning, and I know it's a tiring, it has been a tiring day for everyone. Can I have my slides, please? That side? Okay. Yeah. So I'm here to speak on not how the technique of SICS, but I'm basically going to deal with how can we shift from peribulbar to topical anesthesia. So topical M6, the tips and the tricks for doing these cases. And why topical? Because we are doing our FECO cases and the patients, they go off at the end of the day without having a patch. So why don't we give the same opportunity to our SICS patients? Why discriminate with them? So ultimately, it is the form of low risk and non-invasive technique, but it's ultimately a personal choice. It depends upon you, whether you want to actually shift from peribulbar to topical or not. It's you who is going to decide whether to shift to topical or not. Now, is topical anesthesia safe in M6? Is it actually possible to do M6 under topical anesthesia? Can we do it in all the cases? And do we need to modify our surgical steps when we are going for topical anesthesia? Now, we have been doing our SICS cases under peribulbar anesthesia. We have wonderful echinacea. We have wonderful anesthesia. So do we actually need to move out of our comfort zone? We are having a comfort zone with peribulbar anesthesia. Like every technique, there should be a scope for improvement, and anesthesia is no different. We need to improve our anesthesia techniques also. But it's not that one fine day you decide to jump into topical anesthesia. Now, I decided to sit back and analyze my own surgical cases. So I realized that it was after my 30th case of phacoemulsification that I shifted to topical anesthesia, and it took me 40,000 SICS cases to shift from peribulbar to topical anesthesia. And I was doing my SICS cases in 3 minutes. I was doing it under peribulbar. I was completing my phaco case in 8 to 10 minutes, and I was doing it under topical. So what was the difference in my surgical technique? What am I doing differently for the patient? So why I didn't go for topical M6 earlier? Now, was I worried that it will be painful for the patient? I was at that time using the superior rectus brittle suture, which I don't use now. Will it be difficult to manage a hard nucleus? What if I land up in a complication? What if I have a PCR? Will I be able to manage it? Or was I simply looking for an excuse for avoiding maybe topical anesthesia? So I decided to brush up my anatomy a little bit and study about this. So I realized that it was the sensitive terminations of the fifth cranial nerve, and these are concentrated in the cornea and the ciliary body where we are actually operating. And these nerves are blocked by a very low concentration of drugs in comparison to your motor fibers. The advantages, we all know it has a higher safety level, a better consistency, you have a lower intraocular pressure, and the best part, the return of sensitivity immediately after surgery. Yes, limitations are there. Initially, you have to choose cooperative patients. You have to choose easier cases. When you know that your surgery is going to take a long time, you're anticipating a long surgery, or you know it's going to be a complicated case, better not jump into topical immediately. You can very well go with peribulbar anesthesia. And the proparacaine drops are readily available nowadays. We have wonderful intracameral injections which work wonderfully with both analgesia as well as echinacea. So the technique is the simplest of all. You just ask the patient to look up, instill or drop into the fornix, avoid the cornea to avoid the corneal toxicity. Just ask the patient to close his eyes and your job is done. And initially, an important tip is that initially when you are starting your topical anesthesia, you can apply these drops to both your eyes so as to prevent the squeeze response of the patient. Now, there are 3 ingredients for success of topical anesthesia. You have to prepare your patient, you have to select your patient properly, and you as a surgeon, you have to prepare yourself for the surgery. So regarding patient preparation, the adequate preoperative counseling is very important. You have to remember 4 important things. That the microscope light initially appears very bright for the patient. So start with a dim illumination, we can see in the first video, and then gradually you can increase your illumination. Now, the patient, remember that still has intact eyelid sensation. This is another important issue. Eye movement control. It's better if the patient can understand where you want the patient to exactly look into. And also, it's very normal to feel some pressure sensations inside the eye. So this you need to explain to your patient. Patient selection is the next most important thing. So the patient should be able to understand what you are saying, what you want. You choose the easier cases initially. Check for the squeeze response of the patient, and how you do this when you are seeing the patient in the OPD, you're doing your routine procedures, like maybe you're doing your AT or other procedures. If your patient is not cooperative, then this patient might not cooperate on your OT table. So next is check for whether he can completely follow the eye movements. So with pre-operative counseling and careful patient selection, you can definitely maximize your chances of success and minimize the stress factor both of the patient as well as you as a surgeon. Now, how do we prepare ourselves? Here again, there are 3 issues which I'll be dealing one by one. Sorry. So saccadic eye movements are disconcerting, but when it's a more sudden and forceful movement, it definitely becomes difficult, and here you need the patient's cooperation. You have to be aware that the patient has intact periocular sensation. Can I just take a minute or so? Okay. Okay. So stimulation of the eyelids or a subconjunctival injection or a traction on the speculum might be painful for the patient. The iris retains its normal sensitivity. So at this point, when you're taking out the nucleus, initially you can go ahead with the intracameral injections. So the deciding factors is always the patient, how he is going to cooperate with you. You as a surgeon, how apt you are in shifting from peribulbar to topical. It's your skill, your experience, and also the type of cataract that you are dealing with. So these are the immediate post-operative pictures of few of my patients, and the basic harm before adopting any technique is to advocate before advocating any procedure is not to do any harm to the patients and see the smiles in these beautiful faces. Let all our SICS patients have the same comfort level, enjoy the same advantages as our phaco patients. And hope this presentation could provide a little bit of confidence in everyone to shift gradually from peribulbar to topical anesthesia. Thank you so much.
Thank you, Dr. Jayashree, for those important tips and trips. So with this, we come to the end of the talks for the session. We open the house for any discussion. So if anybody has any questions to be asked to the speakers, yes, please, Dr. Parikshit.
I just wanted to make a comment, 2 comments. I mean, we've seen fantastic surgeries, Dr. Sahu's, Dr. Boramani's, Dr. Kimea, Dr. Anil Shah, who's like a magician in many ways, Dr. Jayashree, Dr. Chinmay, Dr. Manisha. But I would like to say, as a ordinary cataract surgeon, is that we should be, SICS is in many ways a more complex, a surgery where you have to use your mind more than you have to do it when you do a phaco. So it's a surgery that has to be done with a lot of thought, with a lot of selection in how we want to do it, because otherwise we can have persistent corneal edemas, which a lot of our clinical audits show. So, I mean, we have like fantastic surgeons, like we have great players, Tendulkar or Michael Johnson or somebody, but it has to be done with a great deal of thought and caution. That's one. And second, Dr. Jayashree showed doing topical anesthesia, and which also needs a lot of skill and patience, both on part of the patient and also the surgeon, both of them. And there is a very good Laninder test, the looking down, lying down test, and there is Dr. Vimal Rajput, who has done a randomized control trial on it, and he has shown that how we can actually find, by doing an indirect ophthalmoscopy, whether this patient of SICS will cooperate well for topical anesthesia or not. And he has done it with augmented this. So it's not just topical. When in phaco we say topical, it just drops from the top. But in SICS, we also do a lot of things, and we don't have the machine to help us. So giving a small amount of parabulbar, using a small amount of intracameral, and also then doing a topical, it helps in a long way. But
Yeah.
of course, it's the magic of SICS, so even past 6 o'clock, we have a hall still full for the ISM-SICS.
How many of you feel that SICS is a lesser surgery compared to FECO? Just raise your hand. Why? Why you think it is a lesser surgery compared to FECO? So
No,
it
no,
is a
the
less.
question is that you feel the SICS
Inferior,
is lesser
inferior,
than FECO? FECO. Inferior to FECO.
not lesser.
Huh. No, sir.
No,
no
I
one.
want this house to go with the feeling that it is a superb surgery. Only thing you have to learn the right way from the right people, and the result is really superb. The world is working up, and never feel inferior. Think you are an artist in the cataract surgery. Your take-home money will be much better compared to FECO. And FECO people with their autoclaving and so many instruments, infection chances so much, and SICS surgeon can sleep quietly and with a money bag in their pocket.
No, sir. And with the ISM-SICS movement, even people who may feel that perhaps it's inferior to FECO now will not speak out in
So
public.
that is the
saying
message I wanted to give. That is the message I want to give you. You feel proud about your art. That's all.
It is lesser as far as, 1 minute. It is lesser as far as the time is concerned. You can done it very quickly.
Dr. Sujata,
Yeah.
please come
So-
on the mic for your comments.
From the audience, whosoever is interested in contributing in ISM-SICS, we are organizing World Conference every 2 years. The conference is called as Comprehensive Cataract Conference. We have tied up with big institute in the past, and our next conference will be hosted by RP Center, All India Institute of Medical Sciences in Delhi in November. So if you really want to take part, even the juniors, beginners, everyone can take part, please contact us. Those who want to contribute to the journal also can contact Dr. Purvi or visit our website. We want to take the comments from the discussion, Dr. Sujata and Dr. Rajvinder, and maybe the final comments from the chairman, ISM-SICS, Australia and New Zealand, Dr. Vignesh Raja. Please, Dr. Sujata.
I would just like to add that in
Oh, sorry.
times of integrated learning, when we need to go vertically and laterally, I don't think we are there to compare with each other. We are here to complement with each other. So the ones who are learning to go for the FECO way, they ought to know SICS. Likewise, the ones who are practicing FECO at times need to do the SICS as well. So I don't say what is superior and inferior. I think it's like we need to know how to drive the manual car and also the automatic.
Correct.
Because when you go to a place when you don't have, sometimes the machines stop working in places of India where you have the lights going off, and there are times when we need to resort to just a focus light or maybe even a torch, and patient is already uncooperative. So even if you are into that stage, we just extend. And being into a teaching hospital, there are many times we need to resort to convert the FECOs to SICS. So I think that is the need of the hour. One ought to know all kind, whichever vehicle comes your way, you need
Correct.
to drive. So you need to know all your techniques well.
So instead of
Thank you.
talking as FECO surgeon or SICS surgeon, we should be a complete surgeon, learn everything. But in all conferences, you hear the talks, how to convert to SICS in case of FECO. Even today also you'll learn. But you will never hear a talk how to convert to FECO in case of difficult SICS. So this means that SICS covers everything.
Very good point, sir.
It is for black, black person, white person, rich person, poor person, for everyone it is there.
So, Mr. You first.
Professor Ravi Thomas, he has written in an editorial in the Ransco journal that a FECO surgeon who does not know SICS is like a pilot who does not know how to use a parachute.
Yeah, that is very true. Sir, when we think of shifting from the peribulbar to topical, we can in between we can shift to subtenon injection, posterior subtenon. They can be tried in between, so that that is very good way to shift to topical anesthesia for doing small incision cataract surgery. You sir want to add something?
I think, can I?
Yeah.
Yes.
See, in case you're going in for topical and you've already opened the conjunctiva and you have an intracath with you, so you just go use the intracath and infiltrate the subtenons. In case the patient is not cooperating with you, just use a little bit of subtenons. Over a period of time, you'll be able to, actually titrate. There are a lot of people who actually prefer to use subtenons as the main modality for.
Always use something.
1 to 2,
Yeah, yeah.
2 cc, that is all.
So once you tell patient it is no injection surgery, it remains no injection because patient will not come to know about that infiltration, what you are talking.
Dr. Vignesh, final comments from you, please.
No, in fact, I wanted to make 3 points. I would say that a cataract surgeon is not a complete cataract surgeon if they do not know how to do both SICS and phaco. Because like all the talks today have shown, and experts from the audience and comments from the audience have shown, that we need to be versatile enough to do both SICS and phaco to complement each other and to customize it to the solution, customize it to each patient to what they have, more than bailing out, I think we should do what's best for the patient, and a surgeon is not a complete surgeon if they do not know both techniques. And I think it's a very good point. I think we should move out from peribulbar anesthesia completely, because there is that very small risk of globe perforation, in higher axial length or, patient moving. I think subtenons is much more safer, and I think when we are transitioning from subtenons to topical, I think we could go subtenon and then even go subconjunctival and then go topical. And in fact, when I was training in the UK, what we used to do is we used to use the lacrimal cannula, which we use for syringing, syringing. We use that to give anterior subtenons. So it makes no, nick in the conjunctiva, and it's very, very safe. And I think, and like my chairman, Professor Nitin Verma alluded to, I think the biggest aim right now is sustainability in cataract surgery and the carbon footprint. The phaco, each phaco surgery, and especially in the West, when everything is use and throw, the amount of carbon footprint is generated by each cataract surgery by phaco is about 20-25 times that of a simple SICS, and with climate change, I think that is the way to go.
So we have 5 more minutes left. We can take the questions from the audience. Yeah.
Are we justified in charging the same for SICS and phaco?
Yes.
Yes.
I think it's the result that matters at the end.
Yeah.
Yeah.
In fact, the highest charges in India are for SICS. It is 3 lakhs for a monofocal
Dr.
lens
Deepak, you want to say something?
with SICS.
Sir, and I
So
think
what Dr. Sahu said, your take-home money is more in SICS.
I think the other point is
Yeah.
the SICS patients, because we are mainly doing them in black or brown cataracts, they go from counting fingers to 6'9", and they're much more happy than a phaco patient who goes from 6'18" to 6'6". So, and these guys will be happy to pay anything when they get this much vision back, because it's the quantum of difference that the vision has made.
Somebody is on a study on, the patient happiness index, with him. How much is he willing to pay for that kind of a happiness?
On the contrary, I feel we should be charging more for SICS because that
Exactly.
is all about surgical skills and not about the automation that is there.
Yeah. When we are taking the cost from the patient for our machines, why not take the cost for our expertise? Because I feel it's like having a beautiful handwriting, or painting a beautiful painting. So it's your skill. When you are charging for your machine, why not charge for your skill that you are giving to the patient? But yes, you have to give the best of the result to the patient. Exactly.
Yes. Patients never ask which technique you are doing. Yeah. I am doing 100. Yeah.
They always ask which lens you are putting. So put the lens
yeah.
and